born and raised in Victoria and has been in practice for 16 years. He has expertise in prostate and kidney cancer surgery, which are the focus of his urologic practice. He trained at UBC in Vancouver and completed a robotic surgery fellowship at Swedish Medical Center in Seattle prior to moving back home to Victoria in 2008. Jeff will be having an exciting year leading the Victoria Hospital Foundation campaign to raise money for surgical innovation, which will include starting a robotic surgery program at the Jubilee Hospital in 2025. So without further ado, can we please give Dr. McCracken a warm welcome?
Perfect. Well, thanks everybody. Thanks, Holly. It's great to be back. It's like every 2 years at the end of the summer, I get to look forward to updating this talk and saying hi to everybody. So I'm real grateful that as you walked into the golf course that you came upstairs and didn't go straight to the pro shop and get a tea time, seeing how nice it is out there. And also the first day of football with Taylor Swift. So lots to compete with tonight. So I appreciate your attendance. This talk is pretty basic, but it gets kind of more complicated. And one thing that we stick handle in our office a lot is kind of going from the diagnostic phase of prostate cancer into the treatment phase, and then into some of the advanced treatments if things aren't working out the way we're hoping. And we're going to try to cover as much of that today as we can. Now, most of it is, at least the stuff that I want people to take home is conceptual. So the names of drugs and some of the specific biopsy techniques and that kind of stuff, I don't think it's that important that you kind of really nail down the language so much as the concepts. So I find the best way to explain this is usually going to be with analogies and kind of referring to different concepts that we are familiar with to try to explain the prostate side of it. I'm going to talk first about, a little bit of urinary symptom issues and how sometimes that's what brings patients into my clinic. And then we kind of delve a little bit deeper into what's going on and can identify prostate cancer later. So we'll talk about what urinary symptoms are and how we treat them. And then we'll get into, various diagnostic techniques, and then also what the treatment looks like. I'll tell you my kind of spiels about how to differentiate decisions about making treatment. And then at the end of that, we'll get into some of the new therapies that are out there. And I'm not experts in all that stuff, but I certainly feel comfortable talking about it and trying to explain conceptually what that stuff is. We're going to try to hold the questions till the end, but if something's really, really getting to you, just put your hand up and we'll talk about it. I'm happy to stop, reiterate what you're saying to the guys at home, and we'll go through everything from there. So understanding prostate cancer, I think, is an important concept, and I really try to simplify it because when you're looking at the literature or Google or whatever, it's going to be more complicated, I think, than it needs to be. I want to talk a bit about prostate MRI, which has been something that's now been around for about 10 years. I think when I started giving this talk, it was kind of the latest and greatest thing, but now it's a staple thing that we're using all the time. And then at the end of the talk, I'll go through some of the new therapies and just kind of explain how conceptually I think of how they work and what we use those for. So some of these slides have been kind of evolving since I gave this talk, I think first about 8 years ago. And I think the best way to kind of drag everything out here is to do it as the worst case scenario. And that's always the questions that I get asked from patients is, what is the worst case scenario here? So we'll illustrate that and use it as a tool to try to take us through a lot of the concepts. So this 65-year-old gentleman gets sent to my office, and he's been getting up 4 times at night to void, or pee, as we say colloquially. And that's with difficulty. So again, we're going to talk about urinary symptoms a bit. And I have to say that if you're talking about getting up at night to urinate, I mean, I see sometimes 10 or 20 people a day that get referred to my clinic for this issue. And there's a huge dividing line with urinary problems at night between people that get up to pee and it's a challenge, like it takes a long time and they don't feel satisfied when they leave. and people that go to the toilet and just pee and go back to bed. So the difference there that I think is important to realize is if you just get up at night to pee and go back to bed and you're not really bothered by the act of urinating, you got to go get screened for sleep apnea, because that is actually become an identified cause of getting up at night to pee. And I say that in my office, probably 10 to 15 people a day are getting sent for sleep apnea screening. So you start to notice that pattern ever where you're just kind of your bladder's filling and it's 1 a.m. and you didn't drink anything before bed and go to the bathroom and emptying's not a challenge. Think sleep apnea, because that's something that it's unrecognized a lot of the time. If you're having difficulty urinating at night, like you get up to go and it's a challenge, some people will identify that as being more of an issue at night than during the day. And the reason that we see that is often because when you go from lying to standing, all the nerves in your body fire. And what that does is it tightens up your prostate so you don't pee on the floor. And it tightens up your blood vessels so you don't pool blood in your legs and get lightheaded and faint. And that nervous energy sticks with you while you walk to the toilet. And if you're already having a limited flow issue, it tends to be more difficult at night when you go from lying to standing, because that prostate wants to contract. And my concept here about prostates is think of a prostate like a donut, and you got to pee through the donut hole. Now, when you're born, your genetics will determine what your prostate does over time. People always ask me, can I change my diet or get more exercise and I'm not going to get prostate enlargement as I get older? But not really. Pretty much that stuff is predestined based on your genetics and how much of a hormone called DHT your body makes. So prostates have two problems. They're designed to self-destruct in two ways. They can either grow too big or you can get prostate cancer. And these problems can coexist, but just because you have one doesn't mean you're going to have the other, and vice versa. So they can be two totally separate problems. When your prostate enlarges, that donut gets bigger. And the bottom of your pelvis is kind of shaped like a cone. So for some people, that prostate can grow out, and it can grow out, and you can get a really big prostate and you can still pee because that donut hole is never being compromised. But in other people, if you grow even a slightest amount, there's no space to go outwards, and the prostate was going to grow into that donut hole. And now all of a sudden you're peeing through a bottleneck. So what does that cause? Well, you're going to notice, symptoms like weak stream when you go to the toilet. It's going to take a long time. You're going to notice sometimes that you're hesitant. It takes a while to get started. Or when you're finishing urination, it's like Morse code, start, stop, starts long, short, all that kind of stuff. When you leave a bathroom, sometimes you feel like you're not totally empty. Now, there's a second variable that goes along with urination. So it's not just all about being obstructed, because your bladder is a storage tank, but it's also a pump. So that pump in your bladder is a muscle. And that muscle is going to the gym every day and working out every time it's having to fight with a prostate. So what happens to muscles when they get stronger? They tend to get twitchy and they tend to get wanting to do things. And all of a sudden, when you're in the middle of giving a talk like this, you get this urge to pee and you just have to go. I'm doing okay right now. But that's the pump action of the bladder, and that's muscle memory. So if we do a surgery on somebody, like a surgery called a TURP, because people are having difficulty urinating, we're going to go in there and we're going to make that donut hole bigger. So that all of a sudden, when that bladder wants to pump, it's going to be like a fire hose. It's going to go through a very large donut hole. But one thing patients can experience when that happens is that they still have a lot of frequency and a lot of urgency, because the bladder muscle is still really strong. And just like if I went to the gym and got huge biceps and then I stopped, for 6 months or so, those muscles would still be there doing that same thing. So those types of problems don't correct. Now, if we're not going to do surgery, we've got a couple of other options. So we can basically start people on medication. Most common medications, Flomax or Tamsulosin. I'm sure lots of you guys have heard about this drug. And what is that doing? Well, it's relaxing the donut. So there's muscle that holds it all together, and that Flomax medication is called an alpha blocker. It's blocking that nerve system that holds it all together. The prostate falls open and the bladder can empty easier. The other drug is called dutasteride. And what dutasteride does is it blocks that hormone that your body's been making your whole life that is telling your prostate to get bigger. And without that hormonal signal to your prostate will actually start to shrink. And as it shrinks, that donut hole tends to open up. And so now over time, and it can take 3, 6, maybe a year, 3, 6 or months or a year, for the effects of that to actually get noticeable. So when patients start this in my office, I say, you're in for the long haul here. Like, don't come back to me for 6 months complaining that it's not better, because that's how long it's going to take to even see any improvements. And with that, it also brings your PSA level down, because prostate enlargement also drives PSA numbers up. So in this case, this gentleman that's been getting up at night 4 times to pee with difficulty, we'd assume he probably has prostate enlargement because he's struggling more at night than during the day. That's that effect of the nervous energy causing the donut hole to get small. And then when he's up and moving around on his legs, there's not as much stimulation. He probably does a bit better during the day. We check his PSA, it's sitting at 5. That's, about the upper limits of normal for someone that's 65. And if you have prostate enlargement, you do see higher PSA numbers. So because the symptoms aren't really bothering him too much, he's going to start on some dutasteride. It's going to shrink the prostate, and he's going to stay on this medication for the long haul to try to get the improvement that he's looking for. So we give him 6 months of the medication. That's really just time to see whether he tolerates it, because it can cause some rare risks of breast swelling or rare risks of some sexual dysfunction. Interestingly, placebo rates are similar, but this drug has been flagged as potentially causing that. So the first 6-month interval, we're really just hoping that, the symptoms are stable and that he's tolerating the drug okay, because it's the second 6 months we're going to see improvements. But we recheck his PSA when he comes back, because we expect it to drop, because the prostate should be shrinking. And for some reason, the PSA actually went up now. And we're thinking, well, that's not normal. And this is when the urologist is going to take a closer look at things. Now, a urologic prostate exam and a family doctor prostate exam, I have to say, sometimes they can be marginally different. I've definitely identified things on prostate exam that seemed pretty noticeable at times. And in this day and age, we just don't even really know how many patients are even getting prostate exams with the GP shortage and that kind of stuff. So if we find nodularity on an exam, we're usually going to chase after it. And that is here accelerated a little bit by the fact that the PSA has been going up. So when you take this drug dutasteride, you expect that PSA to drop by 50%. And if it's going up, we have to think prostate cancer first. So here's an example of where we would maybe even just go straight to a prostate biopsy, because our suspicion is so strong. And of course, the biopsy is negative. Now, this happens a lot. Prostate cancer can be a needle in the haystack problem, and it can also be like a very prevalent problem. So you can't always guarantee that a biopsy is going to work. We actually say biopsies are probably in the range of 60 to 70% sensitive, as in the ability to detect. So about 1 out of 3 people with a negative biopsy could potentially still have disease present. The way that we refine that these days is with the use of MRI. And so in this picture here, you're going to see that there's a dark spot. And I don't want to make things too complicated, but on this scan, you're going to see this is the rectum. That's on the bottom side of this picture. And then you're going to see this chestnut-shaped prostate. And you can see here the arrow pointing to a dark spot. Now, when we do prostate exams, we only feel the back side of the prostate. We only really feel the side that's against the rectum, because that's where our finger is. So if you have a lesion that's on the front side of the prostate, and that happens probably about 30% of the time, you may not feel it as a urologist or anyone doing an exam. And when you do a biopsy, you may not get there, because the biopsies that we do here typically are through the rectum, and they're going to be really good at getting the back side of the prostate, but not so good at doing the front side. Now, when you get an MRI, there's a scale that is used to determine how likely it is that what they're seeing is prostate cancer. That scale goes basically from 1 to 5, and it's called the PIRAD score. Now, if you're having an MRI of your breast, there's what's called a BIRAD score. So this is becoming language that radiologists are using to help us determine how aggressive we have to be with trying to sort out whether there's a problem there or not. So if a lesion on MRI has all the characteristics of prostate cancer, and they do almost 2,000 pictures sometimes when they do these MRIs. So there's a lot of different phases in and out where they can see different things. And what they're really looking at is how much water content is in the cells. But if they come back and they say, this has characteristically every single thing that is associated with prostate cancer, they're going to call it a PIRADS 5. Now, what does that translate to on a biopsy? It's about 80 to 90% likely that you're going to see prostate cancer on a biopsy when you see PIRADS5. So we take that seriously. If you get PIRADS4, that means you're missing one or two of the ingredients of a typical prostate cancer. And it's still about a coin toss at PIRADS4. So we see about 50% of lesions coming back as prostate cancer. And then PIRADS3 is going to be somewhere below 50%. And that's where there's just a few characteristics of prostate cancer present. So in the context of this type of problem, where the cancer is at the exact opposite end of where we're trying to get with a transrectal biopsy, we're going to need some help to make sure that this gets sampled properly when you get a biopsy done. And that's when we ask for what's called fusion. And fusion is where they use a computer to take these MRI images, and they'll basically slap them right on top of the ultrasound that they're using to do the biopsy. And that allows them to move the biopsy inside of a person and see the actual MR images, because we don't always see prostate cancer on ultrasound. It's usually much easier to see it when you have an MRI. So we call it augmented reality. It's our ability to see something that actually isn't there, but it allows us to target the lesions much better. So here's a picture of a prostate MRI, which is a non-invasive procedure. Basically, there's no IVs or probing that goes on in an MRI. But as you can see here, the tube is somewhat narrow. So patients that have any history of claustrophobia sometimes will struggle somewhat with just feeling like they're in a confined space. Our newer MRIs are slightly larger, so they don't have quite as much of an issue with that. If it's a real limiting problem, then there's sedatives and other ways that it can still be accomplished if we think it's really necessary. Oops. Sorry, up ahead here. Here's kind of what we're looking at with the fusion biopsy. On the far left here, you're going to see an ultrasound image. And that really doesn't show much as far as trying to target the lesion. So this is a different prostate now with the lesion that's on the right lateral side. This is, of course, the patient facing us. And you can see it much better there. And so with the fusion technology, we can actually track where the needle course pass, and we can be certain, or I would say more certain is never a word that we use in medicine, but we can be more certain that the area has been adequately sampled. And that helps a lot when we're dealing specifically with lesions that are non-specific, because if something comes back negative and we're suspicious that it should have been positive, we want to go back and actually look to see whether we think that the biopsy would have accomplished what we're asking it to do. So fusion has been a huge a bonus for us in our ability to detect disease. And the other concept I'll just mention is that when you get a biopsy back, and say it's a systematic biopsy, which means we've gone in there and just checked like the top 12 locations of where prostate cancer can be. We're not actually targeting anything there that we've seen before. And this happens quite frequently because MRIs can take 3 or 4 months, and sometimes we don't feel like we have enough time to wait. But if you have a non-fusion biopsy and you get a micro focus of prostate cancer, I always have to have this discussion with patients where you say like, well, it's kind of hard to say, this might be the needle in the haystack. And imagine this is like a television and there's just pixels out. And so this really isn't a lot of a problem here. But at the same time, it may be that we just glanced off of a larger lesion and there's something more there. So I say it's either the needle in the haystack or the tip of the iceberg. And so when we move into staging, trying to figure out how much cancer is there, that's the question that we have to kind of figure out when we're starting with kind of limited information. In a perfect world, I think if you could get an MRI before a biopsy, you'd probably do that routinely. We used to have access to a private MRI here locally, which got shut down by the Ministry of Health, I think about a year ago now. There still are some options in Vancouver, but realistically, we do have to compromise with either timelines or with the quality of the biopsy because we're still fighting with that timeline. So this patient goes for a prostate biopsy, and we find some Gleason 7 disease. And Gleason 7 is the kind of middle of the road prostate cancer. In patients with other medical problems that are significant, we'll often observe Gleason 7 prostate cancer. If you're advanced age, Gleason 7 usually can be observed as well. If you're 50 years old, you might not do that, just because the timeline and the risk might be more than you want to take on. But we don't see a lot of disease. The PSA seems to have kind of stabilized. And this is something that happens a lot at this stage of life, is that someone's dealing with an illness at home or caregiving, and they have to say, you know what, I'm going to put this on hold for now while I manage things at home. Some patients ultimately say, that's great, I'll deal with it later. So where active surveillance comes in, sometimes it's by choice, sometimes it's not by choice if you have other commitments that are limiting your ability to get treatment. But active surveillance is basically the idea that we're going to try to keep an eye on this, and we're going to try to avoid jumping into some sort of treatment. And most of that is to reduce the morbidity of treatment and the side effects. And statistically, a lot of prostate cancers never kind of come to fruition to cause problems. In a huge study in Sweden, they looked at thousands of men with Gleason 6 disease as young as 60 years old and followed them through their entire lives. And there was only about 5% of people that really suffered from prostate cancer. That I think there was about 5% death rate, and that was with no treatment at all over long periods of time. So when you think about 95% of people escaping, problems, and the number of people that we treat for prostate cancer, there definitely is groups of people out there that really don't need to get treated. And a big part of the later part of this talk that I'll get into is how I'm trying to piece together ways to better understand who can't do this, because that's really what we need to sort out. And at the front lines where urology clinics where we work. So for most active surveillance protocols, we try to get your PSA tested about every 3 months. You typically get a repeat biopsy sometime in the first year to a year and a half. And you're going to want to get your MRIs done probably every 2 years if you can. If there's an increased risk, then you could shorten it to 1 year. Now, the trouble with surveillance MRIs is that we don't even really know what we're getting with that, because they haven't been around long enough for us to really have rules about what we're seeing and what it means. And the other thing is that prostate cancer tends to be slow moving for most local problems in the prostate. So we don't really want to do MRIs too close together, because the MRIs will look the same. And if we're trying to use this to make a decision and we're just saying, oh, it looks the same, every time we see that, we're having to wait another year to see it again. So I often will discourage patients from too frequent MRIs, because the longer the time gap, the more meaningful the difference will be. And if you do it too soon, you're then resetting the clock and having to wait even longer to do the next one. I try to examine patients that are on active surveillance once or twice a year, depending on how far into it you are. So like if it's new, we probably would see you in the office twice a year for prostate exams. And so I'll use another analogy here because I think it's helpful, but active surveillance, there's two concepts I think that you have to understand with it. One is that all these things that we're doing are basically like an instrument cluster in a car dashboard, or like an airplane cockpit, where we're driving this plane and we're trying not to crash. And so we're looking at the instruments there, thinking, okay, what do we got here? And you're going to say that PSA is probably like your speedometer in your car, your altimeter in your plane. That's probably the most variable reading that we get. And it can be the most valuable if it's sending us signals like the PSA is marching up. We're getting to that red line, that's often the thing that's going to spark us into the next level of treatment. Biopsies are great if we see higher grade cancer. So the next biopsy shows Gleason 8. Well, we're not going to sit around and do nothing in that perspective. So the Gleason score and the last biopsy fits in there. MRI results, of course, fit in there. How much tumor did we see? Where is it located? Do the lymph nodes look okay? So all these things are in the dashboard, and your prostate exams in there as well, just making sure things don't feel different or have changed, on exam. So that's our safety net, basically, all these different variables. Now, there's going to be likely another variable in there in the next few years, and that's going to be genetic testing. So right now, genetic testing is in the evolutionary phase of understanding how it affects this state of the disease. They're already using it at the cancer agency. If you have metastatic disease, to determine which drugs are going to be the best for you. But at the front end of active surveillance, it's not yet being done. And that's going back to that 5% of people in that group that suffered despite having apparent low-grade disease in the Sweden study. I think these are the patients that we have to figure out are not appropriate for active surveillance because they probably have a genetic link to that potentially. And I could talk forever about it. I'm going to cut it short because it gets kind of complicated. But there are what are called oncopanels that can be done on prostate biopsy specimens that will basically give you a better understanding than Gleason score. This is a lot of information, you guys. I'm sorry, but Gleason score is antiquated. Like it's been around for I think 30 or 40 years, and it's been modified along the way. But like, what actually is it? This is us looking at cells under a microscope, and we put some stains on them and we say, well, if they look squiggly, then they're going to do this. And if they look square, then they're going to be better. And if they look like they're just blanched and white, then they're going to do bad things. It's not very scientific. Like it is a very observational characterization of disease when we have now like genetic ways to determine exactly what the cell cycles are doing and things that are far more sophisticated than just the appearance of a cell. So I don't want to, Gleason scores got us a long way, but within the next few years, I'm pretty sure that our biopsies will be getting some sort of like genetic testing done to them that will helpfully guide us as to whether active surveillance is truly there. Now, you can imagine if you could do genetic testing on a prostate biopsy with your Gleason 6 or your Gleason 7, and they can say, this is nothing. How nice would that be? Because you could just take all the anxiety out of this process, right? So the open door into genetic testing right now is really going to be interesting to see what sort of information we can get from it. So exciting times from that perspective. So in this case, we're going to go on another 3 months interval there, and the next PSA test has gone up again. So this patient's taking dutasteride, and when you're taking dutasteride, that prostate should be shrinking, and it should be not really getting bigger. So if the PSA is going up, it's telling us here that there's something wrong going on. So in this case, patients decided to get an MRI right away. They don't want to wait any longer. I've got here that False Creek in Vancouver is one place I have sent patients for. If anyone asks if there is an option, that's one place where we could still take the images and use them here to do fusion biopsies. It's the only place I'm aware of, although there is a number of still operational MRI locations in Vancouver, I believe. But the False Creek location is the only one that I've actually had patients go to at this time. So that it promptly, and now we're seeing something new. So this repeat MRI is now showing that there's a lesion that's at the base of the prostate, and this is close to the seminal vesicles. So what does that mean if it's into the seminal vesicles or it's extending outside of the prostate? All these staging systems are historical, and I think that probably every day in my office I get asked, like, what stage is my cancer, doc? Am I stage 4 or am I stage 3? And prostate cancer is kind of a funny disease that way because it's not easily staged like conventional cancers are. There's a lot of different nuances with prostate cancer. And I think the biggest concept that I will get through to patients is, either your treatment works or it doesn't work. And that is like, I think the biggest thing to say with this, especially with active surveillance, like what does a failure of active surveillance look like? Well, it doesn't mean that you die of prostate cancer. It means that we kind of get there too late. And after the treatment, there's going to be problems. Like say you have your prostate removed, well, your PSA may go up afterwards because there's disease that's hiding out somewhere else. So like, I totally oversimplify things, but in my world, it's like either your treatment works or it doesn't work. And you're kind of like stage 1 or you're kind of stage whatever. And all these nuances between, does it invade the seminal vesicles or does it extend out beyond the capsule of the prostate? These things can help us determine whether there's disease outside. Like it can help us predict whether there's a higher likelihood that there's going to be problems, but it doesn't answer the question because not everybody with seminal vesicle invasion is going to have a recurrence after treatment. It just increases the chances. So the staging for prostate cancer really isn't that meaningful if you're going to get treatment. It's all about what happens after treatment? Does it work or does it not work? So you can have basically local prostate cancer. You can have locally advanced prostate cancer, which means the cancer is extending outside of the prostate, and you can have distant spread. And the biggest problem here is going to be distant spread, because that's where, when we go after the prostate, we know that there's going to be trouble afterwards. Locally advanced, we can still remove that. You can still have radiation for locally advanced prostate cancer, and you can spend a lot of time trying to differentiate different types of locally advanced prostate cancer. But with all those cases, you're not really going to know what it means in the long term. So for historical reference, here's the actual staging of prostate cancer if you want to use that stage 1 to 4. So stage 1 is going to be, a small lesion in the prostate, something that's too small for us to feel on an exam. Stage 2 is going to be something that we can actually palpate if we're putting a finger on it. Stage 3 is where it's going to be extending locally in the prostate. And then stage 4 is where it's extended out into some sort of structure outside of the prostate. Here they're showing the lymph node there, but it could just as well be in the bone or somewhere else. So the patient questions I think that are the most important are, is local treatment going to cure my disease? And we can never answer that question, but we can statistically predict the likelihood of that if you really want to know what the percentage is. And there's nomograms that we have for that. There's the MSK nomogram that anyone can Google, and you can put in all the parameters of your prostate cancer, and they can tell you the exact likelihood that it's going to come back after treatment. How do I know that it's localized? And this is a good question as well, because that's changed in recent years. We've always done a CAT scan and a bone scan for prostate cancer staging. CAT scans look for lymph nodes, bone scans look for bone involvement. Now, the trouble with those scans are that they only really tell you if there's something there and it's obvious. So for us to see disease in a lymph node, it has to be swollen, which means there has to be quite a lot of tumor there. And even if we see that, we don't know specifically whether this is prostate cancer or it's, just a swollen lymph node, or some patients have blood cancers that cause swollen lymph nodes that are reasonably benign. So we don't really know that it's prostate cancer. We just know there's something there that's swollen. And MRI has been a great way as well. It shows us these high definition pictures of the prostate. You can see if the tumor is extending locally, and maybe you're in that stage 3 category. And the last question is always, if my PSA goes up, what does that mean after treatment? Here's again another picture of, this is called tumor staging. So this is all about your prostate. And again, it's similar. Stage 1, we don't feel anything. And this is if you say had prostate surgery because you couldn't pee, and we find that there's cancer in the specimen, that's called T1. We feel a lump there and do a biopsy, or T2. If we think that the tumor is expanded into the seminal vesicles or it's on the capsule of the prostate, that's called T3. And T4 basically means that it's actually invading into a structure adjacent to the prostate, which would be something like the bladder. Now, there are treatments for all this, and even bladder and neck invasion and those types of things can still be treated surgically or with radiation. So we talked about bone and CT scans. We talked about prostate MRI. The limitation with these things are we see things, but we don't really know that it's cancer. And that's where PSMA PET has made a huge difference. So PSMA PET is basically an injection that you get that has, I'm going to call them antibodies for the surface membrane of prostate cancer cells. And so when you get this injection, it's going to track through your blood looking for anything that looks like prostate cancer. And if it finds it, it's going to stick to it. So with that technology, we've been able to attach radioactive particles, which we can then see in a PET scanner. So when you see that swollen lymph node on a CT scan, now not only are you going to see it on the PET scan, but it's going to look bright yellow, and we're going to know that's prostate cancer. So this technology has helped us really identify exactly what stage you're at before treatment. It can help before treatment, because if there's a lymph node in the pelvis and you're going for surgery, maybe we're going to have a better awareness that there's a lymph node there that we need to remove at that time of surgery. If you're going for surgery and it shows that there's something in your bone, you may want to rethink going for surgery, because there may be bigger problems that we need to deal with first. So PSMA PET is currently available to people that have non-specific findings on their staging tests. So if you're identified as having a bone lesion or something that they're not totally sure what it is, you can get a PET scan done through the cancer agency. Now, that typically has taken several months to happen, which is not always great when you're in this diagnostic phase and hoping to move forward with treatment quickly. There's a private option in Vancouver where you can do it for about $3,500. The rules for that are a little bit more lax as well. Like some patients can just do it just for the reassurance that it's not going to be positive, even if they don't have abnormal findings. And from what I understand more recently is that the wait list may be getting shorter. And in about a year's time, we're hoping to have the renovation complete in the nuclear imaging department at the Jubilee Hospital so that we may be able to do it here as well. PET scanning in general is actually less expensive than doing a bone scan and a CT scan. It's just the availability of the scanners that is the rate limiting step. And generating the right radioactive particle to do it also has been a bit of a challenge, but it's a challenge that I think can be addressed locally. And then the last concept I just wanted to bring up here is the gap. So patients tell me, well, my CAT scan's negative and my bone scan's negative, so I don't have cancer anywhere else, right? And the answer is, we don't think so. But again, if things move at a microscopic level, we won't really know that for a while because prostate cancer can take years and years to declare itself being present. And although these tests are good, and PSMA PET in particular is very sensitive at picking things up, it doesn't always tell you the whole story. And so that's often where PSA testing will fill the gap after treatment. So this patient decides to have a prostatectomy, and the pathology shows that it was T3B, which means that the tumor had invaded the seminal vesicle, which is adjacent to the prostate. There was some extracapsular extension, which means that on the capsule of the prostate, there's some tumor perforating it, and there's a positive margin. And a positive margin means that when they took the prostate out, they dipped it in ink. And then when they looked at it under the microscope, they can always see where the ink is. And that's where they assume the surgeon basically cut to take the prostate out. And so if they can see tumor that's at that surface level where the ink is, they can only assume that on the other side of the ink may be residual tumor as well, right? So that's the importance of margin status. Now, the prostate has got a lot of layers of tissue on it, and it's kind of like an onion where the skin wants to fall off. So when you take it out, sometimes those margins will get exposed and they're not real. They're basically just an artifact of the process of getting the prostate out or preparing it for the testing in the pathology lab. So we don't always believe a positive margin, but if it's large, if they say it's like greater than 5 millimeters or 10 millimeters, it's probably meaningful. And in this context, where this patient's got obviously a significant burden of disease, you would think that, okay, the story's probably not over here because, you know, we think that there's a fair amount of disease in this area, and it looks like it may even be extending outside of what was removed. So thankfully here, this patient has a normal recovery and they're basically ready for action. So that means that their urination is under control afterwards, and they've made a smooth recovery. So without a prostate in your body and without prostate making PSA in your body, you'd think you should have no PSA in your blood, right? Because, you know, all your PSA was derived from your prostate and it's no longer there. So PSA is a great test after surgery because it should be zero and it should stay at zero. And as long as it stays at zero, we're happy. Radiation is kind of a different story sometimes because it tends to cause PSAs to fluctuate and you don't always know exactly what it's telling you. But in this circumstance, it's simple. If your PSA is zero, we're not going to be worried about prostate cancer. The nomenclature for PSA testing after you've had a prostatectomy is such that that number will be as low as the machine can read. And if they can't read anything, you'll see a less than sign there. So they'll never tell you that your PSA is zero. They'll just tell you what they can detect, and then they're not detecting what they can detect. So that less than sign is important. So this patient's obviously very high risk for recurrence. So they're going to get PSA testing done like, you know, at 6 weeks, that's when all of it should be cleared out of your system. At 3 months, we'll do it again. At 6 months, we'll do it again. And these tests all look pretty good. But at the 12-month mark, now we're starting to see PSA back. And at the 18-month mark, we're seeing even more. And at 24 months, we're seeing even more. So what's this telling us? Couple things. One thing is we had a zero result. So we know this isn't likely to be some surgical thing where we left behind a piece of prostate and the PSA is still being generated, or some people can make PSA in their salivary glands or in areas around the prostate, and it's really not an issue. Those numbers are typically going to kind of float up and down, but they don't have that sort of trend. The second thing it's telling us is that it's appearing to double here, and I've kept it simple with the numbers because it's doubling simply every 6 months. And that's pretty quick, because if you kind of prognosticate 6 months and then 6 months and then 6 months, this number is going to be pretty high in about 3 years. I have some patients that have doubling times of like 2 years or 3 years. And I'm like, we can live with this, because these numbers are like 3 years, 6 years, 9 years. We're going to get up there age-wise. And if we do nothing, we can race all the way to the finish line, and it's never going to get there. But 6 months is quick enough to be like concerned that this is going to be a problem eventually. So this is the PSA recurrence. And why has this happened? Well, it's because there's prostate cancer that has left the prostate and is living somewhere in the body, right? And PSA is labeled to any prostate cell or prostate cancer cell. And if it escapes from your prostate and gets into a lymph node or into the bone, it's going to continue to make PSA in your blood. And because of that, it speaks to us like a language. We can tell that probably the volume of this tumor is doubling about every 6 months. So we go hunting and we try to sort out where this is happening. Now, we already know that there was a positive margin on the specimen. So it's possible that the tumor was extending outside of where the surgery took place, and it may be local. And so with MRI, sometimes we can see a nodule in the prostate. Here's an example of something in the back wall of the bladder. And that is on PET imaging there. You can see it actually lighting up. So when we determine that we think that this doubling time is fast enough and there's enough of an indication that there's something locally around where the prostate is, we're usually going to do what's called salvage treatment. Salvage is a term used for saying we had one crack at this and we need more help. We're going to call it salvage. And so salvage radiation therapy is done commonly in this circumstance. And it's about half the amount of radiation that you would get if you had a prostate there. It is radiating tissue after surgery that is a little bit more fragile, because without your prostate there, the risk of incontinence or leakage or having trouble with the radiation is a little bit higher. But it still works very well. And in statistical terms, if you have this type of scenario and you get radiation to the area around where your prostate was, your PSA is going to go back down to zero permanently about half the time. So pretty good investment to kind of make this problem go away. The second tidbit of information I think is good to know is that recent studies have suggested that the PSA number of choice to do this type of treatment is typically less than about 0.7. So there was a big study recently where they sort of treated people up front and then they waited to treat other people. And what they came to the conclusion of was that you got a little bit of time to get this done without kind of missing the window. And the nice thing for us about this is that for PET scanning, if we're going to send you for a PET scan to see if there's a lymph node or something there that's turned up, typically the numbers need to be at least 0.4. So we have that window between about 0.4 and 0.7 to get this done for patients that have had a recurrence after surgery. And that's usually enough time to get a PET scan done. If the doubling time is really short, say it's doubling every 3 months or something, that doesn't give us a lot of time. It can get close. So there's options. You don't have to get radiation. We can observe it. And we can also use hormone therapy here. So say this patient is now 78. A short course of hormone therapy, which is a drug that's going to get the testosterone levels down, may actually put this whole PSA problem into remission for like a couple of years. Sometimes it's only 6 months, but sometimes it's actually a few years. And so we can use that as a tactic as well if we don't, say the patient's really struggling with urination problems and we're worried that, going back and doing more treatment there is going to cause a problem. We've got a few other tricks up our sleeve. And there's new treatments as well. So there's HIFU and there's something called nano knife where we're actually targeting specific areas Not currently here in Victoria, but in the future, there likely will be some focal therapies for prostate cancer recurrence once we get a little bit better at identifying exactly where it is. Here's just a visualization of where they would radiate for a patient that had a PSA recurrence after the prostatectomy. It's basically the pelvis and around the bladder. And that would usually include the lymph nodes as well, where the lymph nodes go up into the pelvis. So if we don't do radiation, we're going to continue to watch the PSA. And if we don't initiate early intermittent hormone therapy, how long do we let things go before we have to do something? And this is actually another topic of controversy. I think even myself and some of my colleagues are at odds about exactly how far along the PSA will go. Conventionally, these numbers would get very high before we would even do anything. You know, PSA of 40. Imagine going from 0.2 to 0.4 to 0.8 to 1.6, 3.2, you know, all the way up to 40. That's obviously going to take time for people, and there may be some benefit in that. I'm a little bit more proactive with getting started. You know, getting above 10 for me gets a little bit uncomfortable because I just worry that, you know, there could be problems with the bone health. There could be problems with, you know, potential surgical blockages of the kidney drainage and that kind of stuff if the numbers get really high. So I tend to be a little bit more conservative and initiate that treatment early. Now, if you get up into those numbers and you get a scan that shows that there's bone involvement, we typically will start ADT and not stop it. So ADT is removing the testosterone from your blood. And if we see disease in the bone, we worry that your bone is going to get basically weakened by the tumor in there. So intermittent treatment is something that can be useful, but if you have bone involvement, you probably don't want to be letting the cancer come and go because it may weaken the bone over time. Now, just to kind of get a little bit further into ADT, because I love talking about my analogies. So, you know, what exactly is that doing? And I think the concept that you have to understand with prostate cancer is that there's a receptor called an androgen receptor, and there's testosterone that's floating through your blood. Now, testosterone is the key, and the androgen receptor is the lock. And if you've been in my office, you probably already heard me give this spiel. Now, taking away the keys, which is removing the testosterone, leaves the lock there with nothing for them to do. What we've found over time is that the prostate cancer cells are essentially running experiments all the time. And when they lose their testosterone, they want it back. And so, you know, your nucleus of your cell has got the genetic information for every single thing that goes on in your body. And so with time, those cancer cells are running experiments and they're looking for that recipe for testosterone. And theoretically, they can eventually find it and start actually making their own testosterone. Now, when you take away the keys and those cells are running these engines and they're ready to divide and they've got all these proteins and stuff that they're making, getting ready for cell division, and they lose the stimulus to do that, a lot of them die because they can't keep up that pace without actually being signaled to divide. So when you start androgen deprivation therapy, some people get urinary symptoms. They start peeing more frequently because there's swelling in the prostate that's going on. As these cells die, they get bigger. And what they've discovered now is that if we also jam the lock, those cells will have less likelihood of actually figuring out a way around the recipe, and more of them will die off the top. So if any of you guys have been in treatment in the more recent years where if you've been diagnosed with any sort of metastasis, you're likely going to end up not just on one drug to lower your testosterone, but a second drug that's going to jam the lock to help with basically just annihilating as many of these cancer cells up front as you can. The second thing it does is the experiments don't run as well when they don't have the testosterone or the lock. Yeah. So we notice when we put patients on both these treatments that the recurrence risk or the risk that the tumor is going to come back over time or you're going to become resistant to treatment actually declines over time. And the period of time that you get on treatment is actually much better. So those drugs are called darolutamide, enzalutamide, apalutamide. And we're going to get into one more class of drugs as well, which is called abiraterone. And abiraterone is an interesting drug as well, because what it's done is knows those prostate cancer cells are looking for that testosterone recipe. And so what it does is it forces your body to stop making the ingredients for testosterone. So all these little molecules that get assembled to make a testosterone now aren't there for the cells to make them. And again, that causes cell death. There's another drug out there that you can hear about called radium. Radium is a drug that goes into the bone and basically will get soaked into prostate cancer deposits in the bone and selectively radiate them. And now olaparib has become a drug that is being used mainly in contexts where they're finding genetic reasons to use it. So I'm going to get a little bit into the kind of science here, and I may be butchering this if someone actually understands these drugs better than me. But with some prostate cancer, especially if you have a genetic basis for your prostate cancer, part of the problem is how you repair your DNA. So your cells are always multiplying. And when that happens, there's basically a spell checker that has to go along with these strands of DNA that are going out and being mass replicated quickly. So you can't just do it once. You have to go back and double check that the stuff is all correct. So we all have enzymes that are basically in there doing that and making sure when a cell divides that it's not creating, a mutant. When you have what's called BRCA, your DNA repair is not great. Like the ability to spell check these strands of DNA as they go out is impaired. And what that means is that when these cells replicate, they're getting copies of their genetics that are like not proper. And when the genetics don't work well, it unmasks genes. And a lot of these genes are called oncogenes, genes that aren't normally expressed. But when there's not enough DNA to kind of keep the cell going, they start pulling stuff out there. And a lot of those genes will promote tumor growth. Now, there's two different forms of spell checkers. There's two strands of DNA, and there's one strand of DNA. And if you're trying to replicate a cell and the two-strand one isn't working, you always have that one strand one that's at least hopefully getting that one strand out of the two and keeping it well. So what olaparib is actually a drug that goes after the spell checker for the single strand. So for these cells that are like mass replicating and they don't have their spell checker there, but they got the backup one so the cells can kind of still pull together something that will continue on, we're going to go and knock that one out. So the cell really has no ability to do anything to continue on with the replication. And it's kind of interesting because the rest of your cells in the body use that spell checker. And when you're impairing it everywhere. So we sometimes can see with that drug that we can actually get new cancers in other places like blood cancers and other things. But for the prostate cancer cells that are replicating so fast, once you take away the only tool that they absolutely need to do it, the cancer cells will die. And so for patients that have a genetic predisposition, like if you have an ATM gene or a BRCA gene, olaparib is a great drug because it's actually going in there and dismantling the mechanism that the cancer is using to survive. It's an interesting drug in the sense that it's not cheap. And BRCA patients in prostate cancer groups represent something like 2 to 5% of the group. It's not a huge number of people that have metastatic prostate cancer that have BRCA, but we are screening everybody for it now. And most of these patients will ultimately end up on that drug at some point in time. So really interesting. And this is new since the last talk. So in the last 2 years, this drug has basically become a standard of care out there. So exciting times for prostate cancer. I could have done this talk identically for about 30 years. And now in the last 8 years and 4 talks, I've had to change it every time because there's new stuff going on out there. What's not on here is lutetium, which is also a treatment. It's kind of a Hail Mary last stage treatment for metastatic castrate-resistant prostate cancer. So these drugs aren't working anymore, and we're going to try something different. And so lutetium, I've had some success stories with it. I've had some kind of lukewarm stories with it. I haven't had a patient get lutetium that has had no effect from it, but currently it's only used in the context of a kind of last stage treatment for prostate cancer. And we do have access to that in British Columbia, although getting there can be somewhat complicated. I'm going to skip over some of these things that I've explained it uh, quite a bit there. And I just wanted to kind of shift gears here and talk a little bit about my pet project, which has only been going on for about 16 years here. So as you may recall, I was recruited here from Seattle to do robotic surgery back in 2008. And it was a tumultuous time financially in 2008. Our momentum got totally stalled out almost immediately when I got here. And subsequent to that, we've had ups and downs with this program. But to make a long story short, it looks like it's finally going to happen this year. And I've got a lot of people to thank for helping along with this, including some very special donors that have stuck with me in this process and got enough attention to the powers that be to make us the second site in British Columbia to get a surgical robot. And this has a lot of implications for prostate cancer treatment for us. And it's essentially a standard of care in the United States where cost versus benefit is a little bit more flexible. I'm going to talk a couple of slides here about what the robot actually is so you guys can find out. So there's basically three portions of the robot here. You're going to have the robotic arm portion. You're going to have the tower where all of the processing goes on for the robotic arms. And you've got the console there, and that's where the surgeon sits. Basically, we put our hand into like a virtual reality set that allows you to see inside the abdomen in 3 dimensions, almost like you're standing in there. Worldwide, it's become a standard of care for prostate cancer surgery. I think in the United States, currently 93% of prostate removals are done robotically right now. We also use it for kidney surgery, bladder surgery, and there's a host of other useful things it does in other specialties, including thoracics, gynecology, ear, nose, and throat surgery, and cardiac surgery. What's the real benefit of robotic surgery for us? It's really that when we do surgery currently using laparoscopic instruments or our hands, we're working in very small holes and we're using instruments that are very long. And when that happens, we don't actually have the ability to move a needle properly through tissue. So if you imagine holding a needle on the end of a 2-foot-long stick and trying to actually drive that needle through tissue along the curve of the needle, when all you can do is basically rotate and push, it's not ideal. And what happens is tissue gets traumatized, recoveries take longer, nerves recover worse. And when we have these instruments, as you can see, they have wrists. So you can turn your wrist at a 90-degree angle. It adds what's called pitch and yaw to our ability to move, so that when you lay down a suture or push a needle through something, you can do it at the absolute perfect angle and along the perfect curvature to make sure that there's as minimal trauma as possible when you do it. We can magnify the view so we can basically see as close to what we're doing as possible. We can scale our movements, so I can move my arms like this, and we can move it like 1 micrometer inside the patient. So we can do 1,000-to-1 scaling of our movements. It takes away our tremors. It corrects our mistakes. If we do something that it doesn't agree with, it'll just freeze and be like, "Are you sure?" And with the evolution of this robotic system, there's going to be a lot of exciting things coming. So our plan is to get the existing robot, which is in its about 10th year of existence, which is a long time for technology if you've ever had an iPhone. And in about 2 years, we figure that the most up-to-date version of this, which is called the DV5, will be available. So everyone asks these days about AI, and the processing power of the new robot is something like about 1 million times what we have on the existing robot that we're going to get started with. And although it's not official, there's rumors out there that the things we're going to be seeing with this are, number one, it's going to be actually critiquing your surgery. Like, it's actually going to be telling you how you can do better. It's going to be putting you up against your surgical peers as to how well you're performing. And at the end of the day, we think it's also going to be making some decisions, which currently it doesn't. Basically, we control the movements of the robot now. It occasionally will second guess what we're doing, but it's basically not going to make any decisions for us. But in the future, we think that may be quite feasible. The other big innovation with the upcoming robot is that it actually has tactile feedback. So when you, with your fingers in gloves, touch something inside the patient, it's going to touch you back and tell you what you're touching. So one of the criticisms of robotic surgery is everything's visible. We have to kind of see it, because when we touch it, we don't really get any feedback with what we're touching. So you have to see what you're doing. But with the next robot, you'll actually be able to feel if something's soft or firm, or how much resistance you're getting when you're pushing a needle through it. So really exciting thing along the way. This picture on the right, I think, tells a really interesting story about what we can do with this robot. And we're going to depart from prostate cancer surgery for a minute. I'm going to get a little bit graphic. So with ENT surgery, for instance, if you have a lesion at the base of your tongue or in your throat, the only way to get there surgically right now is basically to split your jaw and open things up that way. And that is it's disfiguring. You're in the hospital for a really long time. And because of that, a lot of people choose to get radiation or treatments that are maybe not quite as elegant as surgical removal of something, and may leave you with more long-term issues. But compared to the current surgical approach, is not good. So here you can see a picture of this robot that is actually down a windpipe, and it has two instruments that can suture there. So we can actually go into very small places with this robot, cut things out, and sew them back together. It's a total game changer for minimal access surgery. It also has helped us recruit. So I'm sure many of you know Dr. Ian McCauley, who is, I was going to say formerly, he's currently still one of my closest friends, colleagues, and mentors. He's retired at an early age. But we've managed to recruit an absolute all-star urologist. And part of this is because of the promise of the robot. So Greg Hosier is taking over Dr. McCauley's practice. And he comes with like a resume that's about 15 pages. And I'm 100% certain that if we didn't have the robot coming here, he'd be looking elsewhere. So when you build it, they will come. And then the last thing is just that there's so many things that have been we've been struggling with at the hospital, since COVID, really. I mean, there's been staffing shortages, there's been shutdowns, anesthesia shortages, and the nurses have been stretched very thin. And so robotic surgery patients have very minimal pain requirements. They're going to be in the hospital for much shorter periods of time. And it's also state-of-the-art techniques and surgery. So it's something that people get on with. So I'm just so elated to have something to bring to the nurses and say, hey, things are getting better here. Like we're going to have these patients come up there and they're not going to be having drainage problems at night or, needing a blood transfusion. They're basically going to be just there for a bit of rest and learn how to use the catheter and be going home tomorrow. And it also will decompress our wards just by doing prostatectomy robotically alone. We believe it's going to free up about 2 bed days for like an entire year in the hospital. So 2 fresh new beds just by doing this one operation differently. And that will also help us with the recovery room, which has been an issue as well. So it's been a lot of ups and downs in this. The donors that have helped me do this, I think, are really why I'm here saying this right now. And I think the nursing shortage actually has been to our advantage because everybody wants to help fix that any way we can. We can't make a nurse tomorrow, but we can have this robot here in 10 days and take away some of the demands that are being put on the people that we have. Future of this robot is just to get on a little bit more about that. One of the big criticisms of all robotic surgery is the position the surgeon is in, because nothing can be worse than what we do now. When we do prostatectomies, I'm basically standing on the side of a bed like this for like 4 hours, and you go back and your body just aches for days after that. But the new robot basically is going to have a headset that follows you around. So like you're not going to be actually tied to a certain position, body position, and that is going to help the surgeons maintain longer careers and not be burning out at age whatever Macaulay is. But it can be really tough on your body, and the robot helps a ton with that. One more slide here. This isn't published yet, but this is a huge study looking at robotic surgery just to kind of tout the virtues. 1.6 million people on here. It's not easy to read there, but we're going to talk about versus open surgery. You're 70% less likely to require a blood transfusion with robotic surgery. This includes thoracic surgery and gynecologic surgery. This is all surgery, not just urology. But the thing that gets me on this when I look at it is the 30-day mortality. So some people do die after surgery. It's not common, but it happens. And if you have robotic surgery, you're 57% less likely to die within 30 days of your surgery. I mean, that's like a staggering difference if you're going to choose what approach you want your surgeon to take. I think that answers the question right there. We've got Alec from the foundation here at the back, and we're very well supported with this project, but awareness is key whenever you're trying to change the status quo, especially in a city like Victoria, where word of mouth makes a big difference. So Alec has some cards that talk about the foundation plan for this fall. And I welcome anybody to take one of these cards and give it to a friend or anybody that you think might be interested in being part of the innovation program that's going to happen this fall. The Visions Gala is going to be dedicated to robotic surgery and surgery innovation, which happens in November at the Empress. And I'm going to be extolling the virtues of robotic surgery all over the city for the next probably year and a half or so. So yeah, if you guys ever want to get involved in the program, just let me know. And I think that's about all I had to say. I'm sorry to hijack the prostate cancer talk there with that, but I think we should go back there and take prostate cancer questions or robotic surgery questions if you've got them.